All right. So, of course, today we're talking about case studies in reproductive embryology. My name is Torben Hamilton. I'm a third-year medical student. I'm going to be presenting on these cases today. So we're going to talk about 2 cases from the Journal of Urology, and I will send out the link to the actual case reports in the chat later on, but I'm not going to do that yet because I don't want to give away what these cases are. The title of this publication is definitely a spoiler. So I'll send out that link at the end because I do want you all to have this study that you can read back through. But we're going to go through each of these cases and talk about what happens with this. It's actually a couple of really fascinating cases that I'm excited to share about today. So case 1 is a case of testicular trauma. So the chief complaint is testicular pain and swelling. The patient is a 15-year-old male presenting to the emergency department following a bicycle straddle accident several days ago. He reports pain and severe scrotal swelling, but he waited to see if it would resolve before seeking medical attention. So we have a 15-year-old male. He had an accident on his bike where he straddled, so he had some trauma to his scrotum, and then he had some swelling and pain, but he decided that he was going to wait a little bit before he sought out attention. So this is a few days after the inciting event. So we are imagining that we are evaluating this person in the emergency department for this bicycle accident, and then we're going to follow his case along. So his past medical history, he doesn't have any medical conditions that he has ever been diagnosed with. There's nothing really that stands out in his past. He just has a clean bill of health going into this. His past surgical history. So he, in the past, had a surgery of the penile urethra during infancy to correct hypospadias. And hypospadias is when your urethral opening is found on the bottom of the shaft of the penis. So this actually has some complications. It increases your risk of UTIs. So this is something that is often corrected in infancy. It can be associated with multiple conditions, or it can just be an isolated hypospadias. So when you're evaluating a baby after birth, you're evaluating for all of these things. You're making sure there aren't any other risk factors for other congenital conditions, because sometimes if you have an issue with the genitalia, you might have that might clue you into some other conditions related to, say, the heart or the kidneys. And so you want to make sure that you diagnose these early. But it seems like this person had an isolated hypospadias. It was corrected at birth so that they wouldn't be at risk for UTIs anymore. But that is something to note. And as I go through these studies, I'm going to highlight things that are clues as to the outcome. So here I've highlighted hypospadias because this is something that I want you to keep in the back of your mind as we move forward. So we have had this surgery. Family history is non-contributory. So some of the things that I've presented in these cases, I've added certain things that won't change the outcome of the case. Also, there's a lot of stuff in these case reports that were not mentioned. So usually if they mention it in the study, it's something significant. And oftentimes if they don't mention it, that it's not significant. So we don't have any knowledge of family history that would be pertinent to know. Nobody in this person's family has been diagnosed with genetic disease or anything like that. So we don't have a history of genetic disease or any predisposing conditions. Social history. He is a sophomore in high school. He denies tobacco use, denies drug use, and he denies any sexual activity. Medications. He is not taking any medications for anything. Allergies. He has no allergies to any drugs. Don't really know about anything else, but he did not report any drug allergies. Review of systems. So this part is where we're just going to go through, and this is subjective still. So we are still from the chief complaint up through the review of systems. This is everything that the patient would tell us. So this is just from their own experience. And when we go through these review of systems, it addresses any symptoms that they might have that isn't necessarily pertinent to the chief complaint, but just a general overview, because some things might clue you into a greater systemic condition that's going on. So we always ask all of these questions. So for the review of systems, for general, he has no fever, chills, no night sweats, no weight loss or weight gain. So this is important because weight loss or weight gain that is unintentional can clue you into something like cancer. So we don't have obvious indicators that we have a malignancy going on. We don't have a fever, so we're not thinking an infectious process. And then HE&T, nothing abnormal here, not super pertinent, but again, good to have this information. Cardiac is normal. Respiratory is normal. GI, he has no abdominal pain, no nausea, no vomiting, no constipation, no diarrhea, no blood in his stool or blood in his vomit, even though he has not been vomiting. So we don't have any red flags here for GI. This is important to know because sometimes, of course, anything related to certain areas of the body, you want to know broadly if there's anything else, like if there was a malignancy or a tumor present that could be impinging on other regions, or hormonal influences that could affect this as well. We'd like to know that. So it is important to know that these above systems are negative for any subjective issues. But then going in, genitourinary, and once again, I'm highlighting everything that is abnormal. So we have reports of testicular pain and reports of scrotal swelling. We do not have any hematuria, so no blood in the urine, and no dysuria, which is painful urination. We don't have any painful urination, no blood in the urine, but we do have some testicular pain and some swelling of the scrotum. This is consistent. Again, he had for those of you just joining us, he had a bicycle accident where he landed on the bicycle seat on his scrotum, and he's having pain and swelling. So this is pretty consistent with that. Neuro, no dizziness, seizures, tremors, or paresthesia, so no numbness or tingling or anything like that. Musculoskeletal, he has no other injuries to his muscles or his bones. He has no arthralgia, so no joint pains, myalgia, no muscle pains. So he has no other musculoskeletal pathologies going on. It seems pretty isolated to the testicular pain and the scrotum. He has no rashes, and he has no depression or anxiety. So we have all of our subjective data so far, and we're going to move into the objective portion of the case. So we have vital signs. We have a blood pressure of 110/72. We have a heart rate of 85. We have a respiratory rate of 18. We have a temperature of 98.6. His oxygen saturation is 98% on room air. And physical exam. So we're going to get into this, and I don't have a comprehensive exam. We're just going to focus on some key regions. So on general appearance, he is a well-appearing phenotypic male in no acute distress. So when we look at this person, just as we walk in the room, we can see this person is a phenotypic female, or phenotypic male, sorry. He appears to be male, and he is not in any acute distress. So we're not thinking that this is an emergency by any means. Cardiac, regular rate and rhythm, S1, S2, no murmurs, rubs, or gallops. So that is a normal exam. Respiratory, clear to auscultation bilaterally. So we don't have any respiratory pathology. Abdominal, we have no hernias or scars He has normal active bowel sounds, soft, non-distended, non-tender to palpation, no rebound or guarding. So we don't have any abdominal pathology here. And then GU, we have a circumcised phallus with an orthotopic meatus and healed ventral scar. The testes are descended and palpable bilaterally. And we see some right-sided scrotal edema, Tanner stage 5 of development, and no gynecomastia. So let's break this down. So we have a circumcised phallus. That's not really unusual. But then we have the orthotopic meatus and sealed ventral scars. So this is remnants of the surgery that this person had in infancy. Remember, he had hypospadias. This was repaired. And so we have a scar and we have an orthotopic meatus. This is all related to that surgery that he had, so that's expected to see. We see that the testes are descended and palpable bilaterally. So you notice both testes are present. They are not enlarged. They're not an unusual exam. This is pretty normal, except that we have some edema. So the right side of the scrotum is swollen. And then Tanner stage 5 of development is showing that he is fully developed. So he's 15, but we often see Tanner stage 5 of development occurring in the later teens. So he has an adult stage of puberty development. He's all done pretty much with his puberty, and he has no gynecomastia. So we're not seeing any evidence of breast tissue in this individual. He appears to be what we would call, and I'm putting this in quotes, a normal male. Okay, so there's nothing in this presentation that would indicate anything different from a phenotypic male. And once again, phenotype refers to anatomy, and specifically here it's referring to external anatomy, because when we're doing an exam in the clinic, you're not going to necessarily, I mean, we have internal in terms of the testes, but you're not going to necessarily notice a prostate unless you did that exam. You're not going to, which is still technically considered external genitalia, but you're not going to necessarily know if he has maintenance of the mesonephric duct, for example. That's, you'd have to know. You don't necessarily know if there's internal male or female genitalia. We'd figure that out later. But from what we can tell, seeing this person, there's no evidence that this person is anything but a male. We're going to go into this because this is about to get more interesting. So we're going to ultrasound the testes to make sure that we don't have a testicular torsion. That's kind of the big thing that we're worried about here, is testicular torsion, or any evidence of loss of blood supply to the testis, because we did have some trauma. We want to make sure that this isn't an emergency that we need to urgently operate on. So we get an ultrasound in the emergency department, and we see this picture. Can you all see this? Everyone in the chat, can you see it? So we have kind of this irregular mass here. We have a lot of fluid on the outside. So when we do an ultrasound, things that are more solid usually are going to present more white. This is kind of based on density. So bone is going to appear more bright on an ultrasound. More dense organs are going to appear kind of a light gray or maybe dark gray. Then we have fluid is going to show up as black. So here we have evidence of fluid in the scrotum. So imagine up at the top of the picture is where the probe, the ultrasound probe is. And then we kind of see some granular tissue on this as well. We have, we notice a right testicular rupture with hematocele. So this fluid that we see is blood. A hematocele is when you get pooling of blood in the scrotum. This is what we see here. And this is common, of course, with somebody who has had testicular trauma, there's nothing inconsistent there with that. So we see a hematocele and we see a testicular rupture. But then we also see a 1.7 centimeter circular mass on the right testis with increased flow on Doppler and contrast enhanced ultrasound. So we see this mass here that's 1.7 centimeters and it's circular. And you can see that there is a little bit of black kind of inside this mass here. So there might be some fluid in this mass. There's also it's kind of irregular tissue inside it. And I'm going to show you another picture here in a second. So this is a normal testicular ultrasound, just for reference. So you can kind of see the difference here between what we just saw on our case's ultrasound versus this ultrasound. So we have anatomy labeled out here. We have the testis should be kind of this darker gray, but notice how it's very even in structure. So it's all very regular. It's what we would say it's homogeneous in the way that it looks. Next to it, we have the epididymis, the head and the body. Here we have the tunica albuginea. So this is what we would imagine to be a normal testicle. And then down here, just beneath it in images C and D, we have a Doppler ultrasound, which is going to show blood flow. So this actually might have a little bit of evidence of testicular torsion, because we're seeing, normally we would expect more blood flow here through the testis. You would expect more of this blue and red, and these colors are just for direction of the blood flow, whether it's toward the probe or away from the probe. But we would normally expect some more flow here. So if we were to see somebody in the emergency department with testicular torsion, for example, if this kid with his bicycle accident had a testicular torsion, which is probably our primary differential in this case, this Doppler is probably what we would expect to see. We'd probably expect to see limited blood flow, but then we'd still expect to see this homogeneous structure of the testis. So going back here, we have, looking back at this, this is not a typical appearing testis, right? We're not seeing the homogeny. We're seeing fluid, and we're seeing this 1.7 centimeter mass. So what's kind of the next step to go through? We've done an ultrasound, right? So we see this mass. And our next step, or at least the next step of the people who were working on this case, is a biopsy. So we're gonna do surgery. We're going to look at this mass and see what we have going here. So we do an inguinal exploration, and this picture is what we find in the scrotum. So a typical testis is going to be round. Imagine the feeling of your thumb, like the little meaty part at the base of your thumb. And if you just tense it a teensy bit, that's what a testis should feel like. Anything more firm than that might be indicative of, say, cancer. And then we can see here that this is very irregular. It has a couple lobes here, and that's not something that we would expect. We'd expect it to be a nice uniform round shape, and this is not what we see. So we're going to do a biopsy of this. So we do a frozen section biopsy. So we're going to take a slice of this testis, and we're going to look at it under a microscope, and we're going to put some stain on it, so we get some differences in colors and we can more clearly see what's going on. So looking at this biopsy, I'll explain what's going on here, but do we have any thoughts from anybody in the audience about what we see on this slide? I'll give you all a second to put your thoughts in the chat. Purple things. Yes, we do have a lot of purple things. Welcome to the chat, B. It's all right. So we have a lot of purple, but you can notice here. So this is what would be expected to be a slide of a testis, and we would expect the testis to have a very uniform appearance. But what we're seeing here is a lot of different things going on. Yeah, the large circles on the left are weird. Absolutely. This is not what we'd expect. We see a lot of different regions. You can kind of see we have one half of this looks very uniformly one way, and then the other side looks very uniformly a different way. So we're going to talk about this. So the left side of the picture, this is ovarian tissue. So we have these circle things are follicles. These are ovarian follicles. And we have luteinized cells as well. So these little circles are things that would grow during the ovarian cycle, and you would ovulate these. This would become the ovum that you would ovulate. So we have an ovary on this half, and then on the right side of the picture, we have seminiferous tubules consistent with testicular tissue. So this gonad is half ovary and half testis. So these seminiferous tubules are what would produce sperm. So we have somebody who presented to the emergency department for testicular trauma. So he had a bicycle accident that prompted him to be evaluated at the emergency department. We find a mass, and then we look at this mass on a biopsy, and we can see this person who was phenotypically male. There were no indications of this person having a difference in sexual development. He presented 100% like you would expect a male to present. But then we see here, this gonad has both ovarian tissue and testicular tissue. Yeah, caretaker's on this. Yep, the past surgery, and we'll talk about that. So his labs, our CBC is pending. LH and FSH, which are hormones that trigger the release of testosterone and estradiol, are pending. So we don't know that. Free testosterone is pending. We don't know that. Tumor markers are normal. So we are not thinking that this is a malignancy, because something else that could potentially be going on here is that he could have a germ cell tumor. Those are common in, at least it's one of the more common tumor types in children and adolescents. So this could be a tumor, but we're not seeing any tumor markers or indications that this would be malignant. So we're not leaning in that direction for a diagnosis. But our other labs are pending. We don't know what his LH and FSH are doing. So we don't know how his pituitary is responding to this. We don't know his testosterone levels. We don't know his estrogen levels. All of that is pending. So we're going to do a karyotype and genetic analysis. So we're going to use, first of all, a technique called fluorescence in situ hybridization, also known as Fsh. And this Fsh is where we're going to take a probe that's it's fluorescent, hence the fluorescence. And we're going to tag the DNA with this probe, and it's going to tell us what the chromosomes are of this person. So we do this Fsh procedure, and it results as 46XX with no SRY gene. And this is really interesting because we would expect anybody with external male genitalia to have an SRY gene. So one of the thoughts we might have had was that, does this person have Swyer syndrome or an SRY translocation? But we're not seeing that. We're seeing someone who is 46XX with no SRY, because SRY is what prompts the formation of testes and forms the internal external male genitalia. It all usually stems from SRY. But in this case, we have no SRY present, but we have 46XX. So this person is genotypically female and phenotypically male, with a gonad that has both ovarian and testicular cells. So then we're going to do a SNP microarray, or single nucleotide polymorphism microarray, and this is going to look for mutations in specific genes. So we used the FISH to look at the chromosomes that are involved, and then we're going to use the SNP microarray to look at the individual genes that are related to sexual development. So we take this chip. It looks kind of like a little computer chip, and it has complementary DNA on it. So we take the DNA from the patient, and we're going to replicate it. We're going to essentially put it on this DNA microchip, and the DNA is going to hybridize. It's going to stick to the complementary sequences. So it's going to find the right place to go, and that's how we identify what genes there are. And so we look at this person's specific genes to find mutations, and there is no evidence of abnormal copies of SRY, SOX3, SOX9, or NR0B1. We're not going to go into a lot of detail on these specific genes. We know about SRY, and then SOX9 is one of the genes involved in the SRY pathway. SOX9 is what inhibits the female pathway from happening at all. So we don't see mutations in any of these genes, which is kind of strange. So a lot of this is not lining up for what we would expect in someone with a DSD. Not a whole lot of this is clear yet. So the conclusion of this case, our diagnosis here is SRY negative 46XX ovotesticular DSD. So we have ovotestes. This is something that we call an ovotestis. That is the gonad that we had. And again, it's very interesting that we have that is SRY negative and 46XX. So the question is, and Caretaker's addressing a great point, is this a chimera? And in all honesty, we don't know. We don't know because this patient was lost to follow-up. So this person did not come back to follow up on the labs or follow up on any of this. So we don't know the cause of this person's ovotestes. But the hypotheses that we can kind of infer are, is this an undetected mosaicism within XY cells? So do we have a case where this person might have some of their cells being XY and the majority of their cells being XX? So a mosaic, we don't know. But that is probably more likely the case. Or do we have a single gene mutation with SRY? Do we have a line of cells that have a mutated SRY that we just did not detect on our analysis? We don't know because this person was lost to follow-up. So we don't really know why this person had ovotestes, but they did. And we had clearly an example here of someone who presented with a very typical male phenotype, a typical female genotype, and then they had their gonadal sex or their anatomical sex would be both male and female. So this is a very interesting case. And before we go into the next case, because we do have another case, I want to leave the floor open for questions about this first case. So if anyone wants to comment in the chat with a question or a comment about what we just read about in that case. You have one. All right, Valdranth, I would love to hear a question. Would this person be able to make a baby? That is a question I don't know the answer to, because we would need to follow up with this person to find out if they make sperm or if they have eggs that they can release. Because I don't know if this person ovulated any of their follicles that they had. The patient denied hematuria, so they didn't have any evidence of menstruation. So I honestly don't know if this person would be able to get someone pregnant. I don't think this person had a uterus, so I don't think they would be able to get pregnant. But I'm unsure of whether or not they would be able to get somebody else pregnant. Is the testicle salvageable? I don't know if they took out the entire thing, or if they left any of it in. I'm honestly not sure about that. Caretaker's questions were answered. All right. Well, if you have any more questions, we're gonna leave the floor open later on as well for some questions. And I also have a discussion section after the second case that hopefully will answer some other questions that you might have. So let's move on to case 2. So case 2 is about gynecomastia. So we have, the chief complaint is gynecomastia. So we have a 15-year-old male presenting with worsening asymptomatic gynecomastia since age 12, as well as a painless testicular mass. He noticed the mass appeared a year ago, but he thought it was normal. He denies alcohol or drug use. So this person probably presents to, I don't know, a family medicine clinic, probably doesn't go to the emergency department for this. But for about 3 years, since this has happened since age 12, he's had worsening asymptomatic gynecomastia, meaning he has breast growth, but otherwise asymptomatic, so not seeming to have any breast pain, no discharge, but it's worsening in the sense that his breast tissue is probably growing. So it's been steadily growing since age 12. And then he also has a testicular mass that is painless, that appeared a year ago, but he thought it was normal. So kind of going into this, what are some possibilities that we could be thinking of here, especially with the mass? So this mass is painless, which is a bit more worrying than if it was painful. If we had a painful mass, we might be thinking of an abscess or some kind of infection, some kind of inflammatory process, maybe some orchitis, epididymitis might be concerns, trauma, testicular torsion. Those would be kind of where we'd be going with a painful mass. Yeah, however, we have a painless mass. And Marie, you're absolutely right. We might be thinking cancer. We also might be thinking a cyst. That's kind of the direction that we're going. But we also have this asymptomatic gynecomastia. So we have growing breast tissue. We might be thinking something along the line of a functional tumor. We might be thinking a functional cyst, cancer, or an XX patient with a released egg, possibly. Let's dig a little bit deeper into this case and what's going on here. So past medical history, we have none. Nothing contributory in his past that would set off any alarm bells. Past surgical history, we have none. No surgeries. Family history, once again, non-contributory. No family history of cancer, no family history of genetic diseases, nothing like that. Social history, once again, we have a sophomore in high school, denies tobacco use, denies drug use, and denies sexual activity. So we're not thinking anything along the lines of an STD. Granted, there could be some sexual activity that we don't know about that is just being denied, but there's nothing really that hints that this is the cause. Medications. He's not taking any medications. Whoa, I went ahead too far. Okay. Medications are important because there are certain medications that can cause gynecomastia, medications that might suppress androgen production or might enhance the level of estrogen. For example, if he was taking ketoconazole, is an antifungal that can cause increased levels of estrogen, decreased levels of androgens. If he's taking doubt he's taking an estrogen birth control. If he's taking certain medications that might suppress the pituitary or might suppress testicular function, that might be something of concern here. We don't have any evidence of that. We have no known drug allergies, so not really important. Review of systems. All right, so let's address subjectively any other complaints that he might have. So we have gynecomastia, but we don't have any fever or chills, so we're not thinking a systemic infection. Night sweats usually pertains to tuberculosis. We're not worried about that. Weight loss or gain. We don't have any unintentional weight loss or weight gain. So not thinking of a long-standing malignancy with that. HEENT is normal. Cardiac, it's pretty normal. Respiratory, no history there. Once again, abdominal, we have no abdominal pain, no nausea, no vomiting, no constipation, no blood in the stool, no blood in the vomit, no vomiting. Any of that's normal. Genitourinary, we have a testicular mass, but we have no testicular pain, no swelling of the scrotum, no hematuria, and no dysuria. So once again, we have no blood in the urine. We have no pain with urination, no swelling, no pain. We just have a testicular mass. Neuro is unremarkable. Musculoskeletal, unremarkable. Skin's unremarkable. Same thing. Psych, no depression or anxiety. Okay, so we have pretty much going into this, we have gynecomastia and a testicular mass. So let's move on to the physical exam. We have vital signs. We have a blood pressure of 115/68. We have a heart rate of 72. We have a respiratory rate of 16. Temperature of 98.6. Satting 99% on room air. And blood pressure is important for these conditions, especially because if we're thinking adrenal gland tumors or adrenal insufficiency, anything like that, that can cause disruptions in your hormone levels, especially your androgen levels. If you've watched any of my videos about the adrenal gland, you know that adrenal tumors can have effects on your sex hormones. So looking at the blood pressure, if we saw high blood pressure or low blood pressure, that could tell me that we had an issue with fluid balance, an issue with aldosterone production. So all of these vitals, yes, B, all of these vitals are normal. But that is a reason why we'd be worried about the blood pressure. And then, of course, with temperature and things worrying about infection, if we had a systemic and infectious process, we're not seeing evidence of that here. Yeah, so all of this is normal so far. Physical exam. general, we have a well-appearing phenotypic male with no acute distress. Yeah, and they're 15, so most things would be normal. Yep. Yeah, and I'm going to highlight everything that kind of stands out. Cardiac, and I include cardiac and respiratory on everybody because it's a standard screening. We like to include that, make sure everything is normal and not really sending any alert bells or red flags. So we have regular rate and rhythm, S1, S2, no murmurs, rubs, or gallops. Respiratory, lungs are clear to auscultation bilaterally. Abdominal, no hernias or scars, normal active bowel sounds. Soft, non-distended, non-tender to palpation, no rebound or guarding. And then genitourinary. We have normal appearing external genitalia, Tanner stage 4 breast tissue, Tanner stage 5 pubic hair, descended testes palpated bilaterally. We have a 3 centimeter non-tender mobile mass antero-superior to the left gonad. So we have what appears to be a typical or normal male. We have normal male external genitalia, stage 4 breast tissue. So we have 5 stages of pubertal development. So Tanner stage 4 is almost to the adult range, but not quite. This is expected of breast tissue at this Tanner stage 4 in somebody who is female at this age. A 15-year-old female might be expected to have Tanner stage 4 breast tissue. That's what we have here in a 15-year-old male who appears male otherwise, but has Tanner stage 4 breast tissue, and then Tanner stage 5 pubic hair. So we have pubic hair in an adult appearing fashion. So this person has gone through puberty. He is at pretty much an adult stage of pubertal development. He has completed the majority of his puberty. His testes are descended and they're palpable bilaterally. So they are present. They are not stuck somewhere in the abdomen. But we do have a 3 centimeter non-tender mobile mass. And the fact that it's mobile is encouraging. This might indicate that it's more of a cyst and not really a tumor, or at least not a malignancy, because if something's malignant and it's invading other tissue, it's not likely to be mobile. So we have a mobile mass, anterosuperior, and that's just the location of it, to the left gonad. And 3 centimeters is pretty big for a mass in the testes. So let's take a break for a second and just think about what are we thinking now, based on the history and the physical exam. What is kind of our differential, our primary differential, and then what would our next steps be? Any thoughts? And once again, I understand that there's a slight delay in the chat. Cyst, then cancer. Possibly. B says an ovary. Gonna find out. So if we're thinking between a cyst or a cancer or an ovary, what are we gonna do to figure out what this is? And I can answer that. We're going to do an ultrasound, just the same way that we did for the last case. We're going to do a point of care ultrasound to see what we're dealing with before we make any further decisions. But we're also going to get labs. I guess I have labs first before I have the ultrasound. So our labs, we're going to see, we actually have our labs that have come back. We have a normal LH, we have a normal FSH, so we can see that pituitary function is normal. The LH to FSH ratio is normal. So we have neither one of these hormones are produced in a level that is unexpected compared to the other one. This ratio is often important for malignancies and things. For if you have cells that are producing a lot of LH, but you don't have an increase in FSH that is proportional, that could be a sign that something weird is going on. So we have a normal ratio of LH to FSH. We're not concerned about a pituitary tumor. Our testosterone, however, is low. So we have low testosterone. We have an elevated prolactin. So we have a high level of prolactin produced from the pituitary. And that is responsible for milk production in the mammary structures. We have elevated levels of estrogen, and we have normal tumor markers. So we don't have any evidence that is going to say, yes, this is absolutely cancer. And again, tumor markers are something that can rule something in, but it really can't rule something out. Just because we have an absence of tumor markers does not mean it isn't cancer. So the fact that this is normal is not eliminating cancer as a diagnosis, but it's just not confirmed by the tumor markers at this point. So then we're going to get a CT and X-ray are normal. So we don't see anything out of the ordinary on a CT or an X-ray. So we're going to get an ultrasound. All right, so we have both testes here on this ultrasound. And both of these look very different, and neither one of them are normal. So once again, let me go back to case 1. We're going to look at this other ultrasound that we had. Oh, there we go. Okay. So once again, this is the normal ultrasound. So our testis should be heterogeneous or homogeneous. Sorry, should be homogeneous with this kind of dark gray. We should see the epididymis. It should all be pretty regular in the way that it looks. We shouldn't have a lot of extra space between the scrotum and the testis. So let's go back to the one that we had. Okay. So we have on this left side of the screen, we have a very clearly circular mass here. And then we have in the scrotum, we have a lot of fluid, it looks like. There's a lot of empty space here, which is probably fluid. And then we have this mass, and this diagonal line is very interesting because it's showing that there's something that's kind of solid in here, or this might be an air fluid level. We might have some fluid, but it's odd that we have this color difference between this fluid and the solid. So that's not really normal. And then looking at the other one, you can see we have a testis that is solid, but it looks very irregular. It's heterogeneous and not really homogeneous. We have different things going on. We have little circles of things here. We have some areas of fluid. It looks like we have some small circles here throughout. It's not a neat surface. It's not all one thing. It's very irregular and not really sure what we're looking at here. So we get this, and of course we can't determine exactly what's happening from this. So we have a focal cystic mass with a fluid level. So we have some fluid with an intratesticular cyst on the right. So the left picture is actually the right testis. So we have some mass. We have a mass, and then we have some fluid inside testis. We have a cyst, and then in the left testis, which is the right picture, we have a mass-like heterogeneous structure that measures 5 by 1 by 1.4 centimeters with multiple small cysts. So all of these little circles in here are cysts, and an echogenic linear structure. So you can see it's very linear, very irregular, and there are some cysts present. So what are we going to do about it? We're going to biopsy. So we're going to biopsy, and we are going to send the sections for pathology. And we have these pictures here. So once again, we have two very different pictures with each of these sections. Does anyone want to? Yeah, caretaker, it's a bit weird that there's no pain. Does anyone want to take a crack at these pictures and describe what we see here? And this is very different from case 1, I know, but there's a lot wrong here. Yeah, there's a lot going on. There's a lot going on. Anyone else have any thoughts about this? What are the boxes in the picture? Oh, the boxes are magnification. So that's just kind of highlighting what we see in these slides. So let's talk about it. Let's talk about what we see. On the left scrotal mass, so the mass that we found inside the left side of the scrotum, we have an ovary with fallopian tube and hemiuterus. So this is both ovarian tissue and fallopian tube tissue and a hemiuterus. So we have uterine tissue in here as well, with a hemorrhagic corpus luteum cyst and endometrial tissue. So a corpus luteum cyst is it's a cyst, but the corpus luteum is the structure that is left behind after you ovulate follicles. So you have ovarian follicles. You're going to try to mature multiple follicles at one time for one cycle. The goal is to ovulate one follicle, but you're going to allow multiple follicles to start the maturation process, and then you're going to ovulate one of them. So after you ovulate the one, the others that are not being ovulated, that have already matured, they're going to become a corpus luteum. And that is going to secrete progesterone. And that's responsible for maintaining a pregnancy. So we have here a corpus luteum cyst. So we're producing progesterone. And we have endometrial tissue. So the endometrial lining, the outer lining of the uterus, that's the part that sheds off when you menstruate as part of the endometrial lining. We have endometrial tissue here. We have fallopian tube. We have a hemiuterus, and we have an ovary. So lots of stuff going on. Valdry, it is in the testicle that we found a hemiuterus and fallopian tube and endometrium. And then on the right scrotal mass, we have testicular tissue with focal oocytes, focal retitestes, and focal Sertoli cells. So this other mass it's testicular tissue, it's testis, but this testis has oocytes in it. Oocytes are gametes of females. They're female gametes. They're eggs. We have some eggs. We have some retitestes, which are cell types found in the testes. We have focal Sertoli cells, which is another cell type found in the testes. Sertoli cells are responsible for producing MIF in fetal development. MIF causes the paramesonephric duct to degenerate, so that normally causes inhibition of internal female genitalia. Obviously, we do have presence of female internal genitalia. We have a hemiuterus, we have fallopian tubes. So we didn't have enough MIF to prevent those from developing because we have presence of that here. So this makes an interesting scenario. And we'll talk about this in the discussion, but if we're going to talk about gametes, this person is phenotypically male and has female gametes. So I'd love to see some of the MIF. I apologize for not saying the full name. MIF is Mullerian inhibiting factor. And I have videos about this. So if you watch any of my videos about differences in sexual development, you can learn more about MIF and what it does. But I would love to see the gender critical movement try to explain this scenario where we have testes that are producing eggs and oocytes. That is an interesting one to work through. And then we have some permanent testicular tissue that is Sertoli cells only. So we have, apart from these masses, the cyst and the mass, we have regular testicular tissue that are only Sertoli cells without Leydig cells. So that's an interesting thing here too, is that we don't see a lot of Leydig cells. We did see some in the right scrotal mass, but in the permanent testicular tissue, we don't see any Leydig cells. Leydig cells produce testosterone. So we have a lot of Sertoli cells, but not a lot of Leydig cells present. So our karyotype is 46XX and also 47XXY. So this person is a mosaic. They have multiple karyotypes at the same time. So they are simultaneously 46XX, so simultaneously genetically female, and they have Klinefelter syndrome, a mosaic Klinefelter. So some of their cells are of an XX cell line, and then others of their cells are of an XXY cell line. They have both karyotypes present. So the conclusion of this case, we have a diagnosis of ovotesticular DSD with 46XX predominance. So they are mostly 46XX. And they have Klinefelter XXY mosaicism in the GU tract only. Mosaic is different than chimeric to the extent that a chimera specifically refers to the absorption of another fetus in utero. So if you have cells from two different people, essentially two different gestations, that would make you a chimera. A mosaic, so a chimera is a type of mosaicism. Mosaicism would be the broad umbrella that all of these fall under, because you can have mosaicism and not be a chimera. So this person, for some reason, has their cells in their GU tract are predominantly XXY, but the rest of their body is primarily 46XX. So once again here, we have a phenotypic, well, at least externally phenotypic male, internally phenotypic ambiguous, both. we have a genotypic female / genotypic somewhere in between. So we have a lot going on here. So on follow-up, this person showed that they had their prolactin improved over time. So they had a decrease in prolactin, but their testosterone stayed low. And then at the time that this was published, this person was evaluated further for androgen replacement therapy, and that was the method of treatment that they decided to go with. Both of these cases were published in, I believe, 2017 or 2018. I think it was 2017. So these are pretty recent cases. And they were both published. So at the time of publishing, this person pretty much had followed up, but we don't know much beyond that. So any questions on case number 2 before we kind of discuss what we've learned today? Did the client request androgen therapy over estrogen therapy, and how is the determination made? That's some information I would love to know. It was not specified in the article why androgen therapy was chosen. I would like to hope that they asked the patient what they would want to go on. If I were the physician in this case, I would choose to ask them, but I'm not sure. I'm not sure how they made that decision, but I hope they got consent for it. I'm glad that you're fascinated, caretaker. Both of these cases were very interesting. And I will link, at the end of this discussion, I will link the case reports in the chat so you all can go read the studies yourselves. So let's kind of get into this discussion section. I just have a few teaching points that I want to touch on before we conclude. So OT-DSD is the rarest form of difference in sexual development. So if you've watched my channel, you know that there are cases of Swyer syndrome, which is where you have translocation of SRY. So you might have XX with SRY or XY without SRY. That is Swyer syndrome. That one's decently common. We have Klinefelter and Turner syndrome are both very common, probably the most common. And then there are things like androgen insensitivity. There's persistent Mullerian duct. That's another one. There's 5-alpha reductase deficiency, and so on. There are a lot of differences in sexual development, but OT-DSD, the one that we saw today, is by far the rarest form, and it's found in less than 1 in 20,000 people. But that being said, even though it's found in less than 1 in 20,000, that's still a lot of people that have this. There are still people that have it. And as we see, this is not something that's hypothetical. This isn't a thought experiment that we just decide, well, technically the science could do this. No, these are actual cases. And as we saw today, these 2 cases are real patients, real patient presentations that showed up in somebody's clinic or in somebody's emergency department. So we do see these. So even though it is rare, even though it's atypical, that does not mean it is irrelevant. And it does not mean that we can ignore these cases. They are relevant and they should not be left out of discussion. The average age of this diagnosis is 11 to 16 years. And it's usually a delayed diagnosis because most of these people present with a typical phenotype. As we saw in both of the cases today, most of these people have a typical or a normal phenotype. They look like anybody else would. There's nothing in their presentation that would clue you in to them having a difference in sexual development. So it's often not caught. You don't catch these because they have no symptoms. they're often, they don't have a reason to be getting these diagnoses. We don't karyotype everybody. We don't do that SNP microarray on everybody. So these cases are often delayed because something else is going to cause them to be evaluated for something else, or they're going to have symptoms associated maybe with infertility. Infertility is probably the most common reason that people would find out that they have a DSD, because a lot of times you would get infertility, and that is a reason to investigate, but that would mean that you are delaying the diagnosis. And then also in these cases, you find kind of symptoms at puberty. And so that's why we get into this age range of 11 to 16, because this is when these children are going through puberty and they might have some variations in their puberty, which might prompt investigation. Yeah, and Jenny makes a good point. 50 million of that one rare condition. Yeah, so that's a good question, Jenny. Should each newborn be tested for karyotype? I don't know if it's necessary to. I think, well, and there are ways to diagnose karyotype, and some parents, I think, do choose to get karyotypes in the prenatal monitoring, but it's not standard, and I honestly don't see a reason why it would need to be done. Yeah, so this is often an incidental diagnosis due to imaging for other conditions. So take example of the first case that we saw today. There was nothing else going on, no abnormalities with puberty. That person had a normal pubertal development, but he had a bicycle accident where he had some testicular trauma. And this trauma caused him to go in and to get that ultrasound. We would not know, no one would know that he had ovotestes if he did not get that ultrasound for the testicular trauma. It would have gone unnoticed. So the most common karyotypes associated with OTDSD, the most common is 46XX, which, as we saw in the first case, that would be the most common one that we see to have ovotestes is 46XX. And then another option that is less common would be our second case of 46XX with 47XXY, or mosaic Klinefelter. That is a less common. There are other combinations as well that you can see this, but these are the ones of note in this publication, with 46XX being more common than 46XX with the mosaic Klinefelter. The mutations involved in this, and the first case, we didn't see any mutations, but we also didn't have any follow-up with that to really confirm. And then in the second case, I didn't see in the paper them mentioning any specific mutations involved, but sometimes you can have a single gene mutation or mutation of multiple genes that lead to this process. And the more common one is the presence of SRY. Of course, SRY is the catalyst to male embryologic development. So SRY mutations would, of course, contribute to this kind of presentation. The next category would be if we have a gain of function mutation in any gene that stimulates testicular development in an XX fetus. So if you have a gene, let's say you have a gene that has a function of causing the testis to become a testis, to cause this indifferent gonad to become a testis and secrete testosterone and develop in the normal course that a testis would undergo. If you have more copies of this gene and more copies of the protein produced by this gene, it's called a gain of function. So you're increasing the amount of this gene that stimulates testicular development. You're going to cause increased testicular development. And some of these genes that do this if you have a mutation in NR5A1, SOX9, or SOX3. We won't go into detail about these specific genes, but if you are curious and want to look up these genes and what they do, if you have a gain of function in any of these 3 genes, you could potentially get an ovotestis. The next category are loss of function. And a loss of function mutation is the exact opposite of a gain of function. These are genes that usually repress testicular development. So you have some genes in somebody who is going to develop into a phenotypic female. They have some genes that are going to cause repression of the testicular pathway. And so if you lose the inhibition, if you inhibit the inhibition, you get stimulation. So loss of function of the genes WNT4, and this is one that we see in my videos, that WNT4 in conjunction with having no SRY is what causes the ovarian pathway to happen. So if we lose function of WNT4, we're going to stimulate or be more likely to stimulate testicular development. And there's something called circle syndrome that I mentioned here. And circle syndrome has a loss of function of WNT4. So you might have a difference in sexual development, but you also would present with kidney, adrenal, and lung dysgenesis. So you're going to have some issues there with circle syndrome. So if you were to have a patient, probably an infant or a fetus, that has kidney, adrenal, or lung dysgenesis, that would be circle syndrome. You can suspect a WNT4 loss of function mutation. If you have lung dysgenesis, it's probably lethal. So you might not see a lot of people live with this condition, but it's there if you want to look into that. And then RSPO1, or I like to read these all out as words. So RESPO1 is a loss of function mutation that can lead to a difference in sexual development. It can be involved in ovotestis formation, but you're also going to see something called palmoplantar hyperkeratosis. So that is extra keratinized tissue. So the keratin is what makes your skin. It makes it a skin-like texture. But if you have too much keratin, it'll make your skin very rough. Like if you work with your hands a lot and kind of have rough hands, that's extra keratinized skin. So palmoplantar hyperkeratosis is going to be rough patches on your hands and your feet. And if you see palmoplantar hyperkeratosis along with a difference in sexual development, it is likely that it is due to a loss of function in RESPO1. So clinical presentation. Apart from the cases that we saw today, we had our 2 cases, but there are other variations of how you might see this present in a clinical scenario. So first of all, we have bilateral gynecomastia, as we saw in the second case. That patient came in with 2 developing breasts in someone who is phenotypically male. So we call it gynecomastia. Bilateral gynecomastia is kind of a red flag, letting you know this is potentially a difference in sexual development, but very rarely could be an ovotestis. It could also present with hypospadias. And this is something that we saw in case 1. So remember, going back to the first case that we saw, we had a surgical history that was correction of hypospadias, where the urethral meatus is located on the bottom of the penis, predisposing to UTIs. So it is surgically corrected most of the time. So we see hypospadias in a lot of people with ovotestes. So this is one way that it can present. So in our second case, our kind of clue that we had ovotestes was bilateral gynecomastia. And then in case 1, our kind of red flag was hypospadias. But there are some other presentations that might happen. And this one is very, very interesting. And this is one that I love to talk with GCs about, because we get cyclical hematuria. Think about this. Hematuria is blood in the urine. And if somebody has blood in their urine in a cyclical fashion, so probably monthly, and usually if this starts around their puberty, if they're going through puberty and they start having regular cyclical bleeding from their genitals, this is a period. This is a male, a phenotypic male who gets a period. So that is one way that you might know somebody has an ovotestis, is if they are a phenotypic male with a period. They also might present with delayed or absent puberty, of course, because if you're having differences in estrogen production or testosterone production, you might not have enough hormones to stimulate puberty development. And we didn't see this in either of our cases. Surprisingly enough, we saw both of them had pretty typical puberty. They had normal onset puberty. They were actually like at adult stages of development around age 15, which is kind of the young end for someone to complete their puberty. But some cases you might have people who don't have puberty at all, or they might have a delayed puberty. So that's one thing that might clue you in. If they undergo a puberty incongruent with their sex assigned at birth. So again, if we have someone who presents as male, they have male external genitalia, and then they suddenly grow breasts, and they have breast growth throughout their puberty, like we had with our worsening gynecomastia, their puberty is incongruent with their sex assigned at birth. So if you are a male and you undergo a female puberty, chances are you have a difference in sexual development. So that is a case that might clue you in. Cryptorchidism is undescended testes. If you have testes that are not descended, there's potential that you might have ovotestes, because as we know, ovaries stay inside the abdomen. They do not descend. Well, they descend from the thoracic region, but they don't descend beyond the pelvis, whereas testes do. So if you have gonads that are not present in the scrotum and you find them within the abdominal cavity, then there's potential that it is ovotestes. Sometimes these people can present with deafness or CNS impairment. So if you have sensory impairments, or if you might have seizures, things like that can be indicative of nerve migration or neuron migration in embryology, because you have neurons that have to migrate in order to form your nervous system. So having deafness or having a CNS impairment might clue in that you might have some other abnormalities with embryologic development. So while this does not necessarily, it's not a diagnostic, it's not like a definitive diagnosis. You can't take someone who has deafness or has seizures and say, you have these, so you must have ovotestes. That's not what I'm saying. But if you have these, it might be worth investigating other congenital anomalies that might be present. And short stature. So if somebody doesn't grow to be as tall, that is often a sign that they have a high amount of estrogen. Estrogen closes growth plates and is going to not allow you to grow as tall. So if you have a short stature, particularly somebody who is phenotypically male, it might indicate they have high levels of estrogen and would be worth investigating their estrogen levels. All right, so we can have some complications. So of course, with anything that presents with a variation in anatomy or a variation in hormones, there might be some associated risks. And I don't know for sure what the data is in terms of percentages and how significant these are versus being a correlation. But it's been noticed that people who have this Klinefelter mosaicism have an increased risk of malignancy, especially with extragonadal germ cell tumors, because people with Klinefelter syndrome have been shown to have increased risk of extragonadal germ cell tumors. So germ cell tumors, tumors of the ovarian tissue or testicular tissue, but outside of the gonads. If you find it somewhere else in the body, that can indicate that you had germ cells that didn't migrate properly. And this is seen in people with Klinefelter. So if you have Klinefelter mosaicism, you might be at risk for these malignancies. You also might be more at risk just with ovotestes in general. You might be more at risk for having multiple cysts present, because if you have high levels of activity of hormone production, you could be at risk for cyst formation, which might cause a lot of pain and it might need to be addressed. It could also predispose you to having sexual dysfunction. Of course, variations in anatomy and hormones could cause some difficulties with sexual function. So that's something to look into as well. So we kind of talked about what difficulties there might be in diagnosing these conditions. So once again, having a typical phenotypic development and an asymptomatic presentation could mean that it is more difficult to diagnose these conditions. Also, something that we did not really talk about, but was kind of implied and something that a lot of you in the chat noticed when we were going through these cases, is that they mimic a tumor or a hematoma or some other type of mass in the scrotum, or even if say they had undescended gonads in the abdomen. If you had an abnormal mass in the abdomen, this might mimic a tumor or it might mimic a hematoma. You might think that this is something else because it is so rare. You might automatically think that it's a tumor, and so it might hinder your diagnosis. If you were to treat somebody for this tumor and not investigate further, you might misdiagnose it. If somebody had a sex assignment surgery, it might mask the presentation. So in our case with the hypospadias, he had a surgery to correct the hypospadias. So if you didn't know that somebody had that surgery, it might not let you know that this person had a clue that they had a DSD. And sex assignment surgery isn't really done anymore for cosmetic reasons. It used to be common that if you had a DSD, the doctor and the parents might have a conversation to see which surgery the child would undergo in order to present more cosmetically normal. That's not really done anymore because we've learned that it's better to wait and to let the child make their own determination of what they want their body to look like. If they want to change their body at all, some of them don't want to undergo that surgery at all. So the only surgeries we do now are to correct for hypospadias due to risk of infection, because that can be life-threatening. We only intervene with DSDs if they are life-threatening or health-threatening. So we don't do these surgeries anymore, but if somebody had a surgery done to change their cosmetic appearance, that might it might prevent somebody from having this properly diagnosed. And then variations in presentation, of course, because not everyone presents in the same way. There is no cookie cutter, this is ovotesticular DSD. You're not going to see that. As we saw, even in just our two cases, people are very different in how they present. No one in medicine is ever a cookie cutter. So it's important to be aware that no two people are going to present in the same way. And so that can be difficult for diagnosis. So where do we go from here? We went through these cases. We learned about ovatesticular DSD. So then how do we use this information in everyday practice or in medical practice or in your conversations with gender criticals? How do we use this information? What does this mean for us? So ovatesticular DSD is an example of gonadal sex existing outside of the binary. This is a very clear example that people exist that do not live purely in a male or female state. There is flexibility here. It is a spectrum, a bimodal spectrum. And the purpose, again, of doing this was to take this out from being a hypothetical and turn this into a real situation. Let you all know that these are real patients, real people having real experiences with this. It is not a hypothetical. Now you have data. You have real cases of this happening. OTDSD is often an incidental finding and may go undiagnosed in the absence of investigation for another condition. So for people in medicine, this is an application for you. This is an incidental finding, and you might not know that somebody has this in the absence of needing to get an ultrasound or needing to get a karyotype for another reason. And then using this point for just everyone in everyday life, you don't know who has this. As we saw, we had somebody who had no idea that they had a DSD at all. You would not know that this person had ovatestes. So we don't really have the right to assume. You can't always tell. The GCs love to talk about how you can always tell what someone's sex is, and you can't. You cannot tell what these people have going on in their bodies. So it's incidental, and it might go undiagnosed. Phenotypic males with OTDSD may menstruate. They might have cyclical hematuria at puberty. And this was a point I wanted to mention because somebody has been in my comments telling me that if you menstruate, you are female. Or if you have ever menstruated, you are female. This case shows that you can be a phenotypic male and menstruate. This can be normal for some people. And the last point I wanted to leave with is that biology is not always consistent with external appearance. Instead of making assumptions, consider that you may not have all of the information. Also, consider that you might not need to know all of the information. People do not have to disclose to you what their anatomy is. They do not have to tell you what their hormones are. This is information between them and their healthcare team and possibly people that they are having sex with. But anybody else, they are not obligated to tell you. And also, even if you are a healthcare provider, even if you are on their healthcare team, people have autonomy. They do not need to tell you. Sure, it might be better for them to tell you if they have knowledge of this, but people are autonomous. They are under no obligation to disclose this part of their experience with you. It is none of your business. Just understand that people like this exist and they do not have to tell you about it. It is none of your business. Leave them alone. So that is my presentation. Here are my references, and I'm going to put the link in the chat, and we can have kind of a Q&A session here for the remainder of this. I'm going to put the link in the chat, but does anybody have questions about what we've talked about today besides questions that we've already addressed? Okay, so if you have any additional questions that I did not get to, feel free to hop in my Discord, or you can message me on Twitter. I'm on Twitter. I'm also here on YouTube. I'm on Twitch. Feel free to ask me these questions anytime. I'm going to put the Discord link in the chat. Yeah, it is 17 plus. If you're in the Discord, it is 17 plus. We have some content. Oh, Caretaker's got the link. Awesome. You can also ask questions in the after show chat. I might hang out a little bit if anyone has questions. But otherwise, I think I'm going to sign off. Thank you all for joining me. I'm glad that this was successful and that you all liked it. I'm going to edit a copy of this down, post it on the channel so you can watch it later. But thank you all for joining me, and I will see you all next time.